We're going to be discussing the role an occupational therapist plays and how occupational therapy can help you manage your pain. I'd like to introduce our wonderful guest today. We have HSS physician Dr. Jeffrey Ciccone. He treats a wide array of conditions which focus on acute and chronic pain management. He specializes in interventional spine, sports, and musculoskeletal medicine and procedures. We also have HSS occupational therapist Preston Lockwood. He specializes in the upper extremity and is a certified hand therapist. We're so glad to have you both here. Thank you both for joining us today.
Thank you.
Okay, so while this webinar is going to be focused on occupational therapy, I'd like to first talk about pain. So Dr. Ciccone, if you don't mind getting us started and helping us to define pain. And Preston, of course, feel free to jump in. So Dr. Ciccone, can you define what chronic and acute pain is?
Right.
And
so
what are some of the differences?
Yeah. So definite differences, chronic and acute pain. Acute, is a little bit more self-explanatory for most people. It's usually there's usually something that happened that you can think happened, whether you fell, you pulled a muscle, you did some sort of trauma or did some sort of movement in a bad way. And then, kind of right after, 24 hours after or so, you felt a pain in that area and maybe some pain radiating to somewhere else as well. So usually when we say acute pain, it's usually within the month of something that occurring, maybe even a little bit shorter time span, but within the month of something that someone can point out to, hey, I did this and now this happened. This is what's bothering me after. We would usually define that as an acute pain. And a lot of times acute pain can really kind of just get better with certain things like, the typical rest, ice versus heat, compression, and then obviously help with our physical and occupational therapists, of course, if there's something that's more, muscular or something that can kind of get it over. Chronic pain is usually more defined if you wouldn't necessarily be able to point it all the time to something that happened. It can be something that happened that is then just still ongoing past the month, maybe even into 3, 4, 5 months. But usually once you get to the 3-month mark and you're still having some sort of discomfort in that area, then we start to consider it a chronic pain condition. And at that point, when chronic pain is going on, the initial kind of injury is probably gone, meaning there's not as much of an inflammatory response ongoing. But what is going on is the nervous system is kind of taking over and getting kind of like a little rewired and saying, oh, you have pain here and there's still an injury going on where there really isn't. So it's almost like a little bit of a misprogramming, if you can think, like on a computer. Or sometimes it's a little bit of a chronic inflammation and there's something structurally wrong, and that's what's giving you the ongoing kind of chronic pain. So it's a little bit more than just that acute kind of injury that got better. So usually at that 3-month mark is where we start saying it's chronic. And also we know there's something else a little bit going on in the nervous system sometimes, whether it's more central, which we consider coming from your brain, or something in the outside, like something around your hand or in the periphery.
Okay, great, thank you. When dealing with pain, why is a pain management team important? And who is usually included in a pain management team?
So pain management team, usually a few different people. It could come from a few different physicians. It could come from someone like myself, who's trained in pain management, or also my colleagues in physiatry who are also trained in pain management, but sometimes have a slightly different take based on their training in it. So usually the two of us. That team, either one of us should be involved in terms of the physician. And then the other, definite clinician that should be involved is either physical therapy or an occupational therapist, depending on what the injury is, what the problem is. And obviously that's what we're going to get to today a little bit. But that's kind of the core of the team that we always say. Other people that could be related to the team when things become more chronic, if there's something that is something kind of physically wrong, meaning in the structure of either whether it's your spine or your joint, that is when we think about is there a surgeon that is involved, whether it's going to be surgery or not, just to have that kind of input, whether something has to be physically fixed. And then some other people on the team that could be involved are, if there is a history of rheumatological illness, meaning if you have rheumatoid arthritis, psoriatic arthritis, these other types of things, that, whether that person should be involved or not, because sometimes there's some medical therapies that should be involved in dealing with that as well.
Great, thank you. Could you explain some common self-management techniques that are used to manage pain?
So self-management techniques, at first you can definitely do the typical rest, ice, and compression, on a specific area. Obviously, if it's the spine, it's a little difficult, but if it's something like a joint or a leg or arm or something like that, the compression can definitely be something, whether it's a basic, at least a flexible kind of compression sleeve that you can buy at your pharmacy, or local surgical supply store. Anti-inflammatories, as long as it's okay to take, is always an initial thing that you should try, or Tylenol, within the, a recommended kind of dosing that's, on the bottle. Those are all initial things. And then if there's swelling, we tend to say ice is a good thing to do, because sometimes swelling is actually a good thing because you're bringing some blood flow to the situation, which means you can bring some healing factors to the injury. But at the same time, that could get too much. And sometimes the swelling is what's actually causing the pain, and then it gets into kind of a bad cycle. So ice is definitely something. If you are able to stretch, that is something that's initial. And obviously, you might need the guidance of a therapist or someone like me to kind of look at it. But if there's anything you can look up, online, before you get in to see us, basic stretching is something you could do at home as well. And shouldn't be too much of a, you wouldn't be really injuring yourself too much with very basic light stretches in the injured area.
Right. So you mentioned using ice to help with swelling. Is there times when heat should be used instead?
Yeah, so there's a big debate. Everybody's going to kind of say something a little bit different, whether it's, ice or heat. In general, heat brings blood to an area, okay, and ice starts to kind of bring it down. So if you're kind of already getting into a physical therapy regimen or occupational therapy regimen, or kind of doing something with activity in general, what I tell people, and I think a lot of people do say this, is maybe do heat before the activity. So you're kind of getting it loose and bringing blood flow to the injured area, and then ice down after, so that, we can kind of start calming down any sort of inflammation that's going on.
Okay. And what should you do when these techniques are not enough? If you're trying self-management techniques, but you're still having a lot of pain?
Basically, that's when you should first definitely, I think a good thing is to see your primary care physician first, because sometimes it could be something else that's going on, which is very important. And then if they don't see anything very serious going on that's beyond the musculoskeletal system, or the nervous system, that's when you should see someone like me or my physiatry colleagues. And then could be also at the same time, you can see a physical therapist, occupational therapist, without us, saying you have to. That is an open thing these days as well. So, which direction you go to first is kind of, there's no right or wrong way, because we tend to all work together anyway. And we will refer to our friends in therapy or vice versa when it's needed. So I think either direction is very good.
Awesome, thank you. So now that we have a better understanding on pain, I'd like to talk about occupational therapy and how that ties into pain management. So Preston, could you start us off by explaining what the role of an occupational therapist is?
Yeah, so an occupational therapist is a therapist that focuses on returning you back to your occupations, which is defined as anything that occupies your time. So quite often we'll look at what kind of activities are meaningful to a person and how we can best adapt the environment or the activity to make them as independent as possible.
Okay, great. And what is the difference between a physical therapist and an occupational therapist?
Yeah, good question. So PT and OT, we do have two totally different entry levels. Physical therapist is going to have their doctorate in physical therapy to practice, and a OT is going to have their master's in occupational therapy to practice. I'd like to think of it, if you can just kind of globally look at it. PT is going to get you moving from point A to point B safely through your environment. And OT is going to get you kind of interacting with your environment and doing what you need to do when you get to that place. So if you're going to think of an example, PT can get you moving from the bed into the bathroom. And then OT is going to take over and kind of take you through everything you need to do while you're in that area.
Okay, great. Thank you for specifying that for us. So when should you see an occupational therapist and what should you expect when you're going to see one?
So I think the time to see an OT is when you feel that there is some kind of barrier to your functioning or your performance of your occupations. Sometimes, specifically in my setting, if someone is having difficulty with button snaps or zippers or cooking because they feel like they're dropping a lot of things, they've lost strength, or they have pain in their elbow or wrist, then that's like a time that they should probably seek out OT's consult. And because we do work with all age ranges across the lifespan, it does look kind of different depending on what the person specifically needs or wants to do.
Okay, and when going to see an occupational therapist, could you explain how an OT would approach pain or how you would go about treating pain?
Yeah, so as previously mentioned, we do kind of look at things a little differently in terms of acute and chronic pain. We'll use more modalities in the beginning stages. When the pain is more acute, we'll do the compression, we'll raise or elevate the arm, resting it. In hand therapy specifically, we do different kinds of positional orthoses or splints that are over the counter in order to try to calm things down or rest those structures. I think one thing that I see a lot of is pain associated with an arthritic flare-up. So we might look at, in terms of like the doctors talking about NSAIDs, which is kind of beyond my scope, but we'll look at modifying grips and handles in order to reduce the demand on your hands. We do splinting to kind of reduce the pressure and demand at the base of the thumb or wherever the arthritis is located. And we just talk about activity modification in general, again, to make yourself, to continue that independence, but to reduce any kind of extraneous demands on muscles or joints.
Okay, Dr. Ciccone, could you give us an example of when you would refer someone to an occupational therapist or look for an occupational therapist to help out one of your patients?
Yeah, I mean, very specifically, some of the things that Preston said when, if someone's telling me, they have pain, it's chronic, but it really gets worse during certain activities where maybe we have to just modify how they do those activities, then I definitely am going to send them to one of my friends here, like Preston, to kind of help, go beyond what I can kind of give, because they have the right ideas for it. And if splinting and things like that are the right idea to kind of, take pressure off certain situations, certain angles that are happening when someone's buttoning or whatnot, that is something. A very specific example, I've had in the past, someone like a professional violinist, they have very kind of specific issues in one of their joints in the thumb that, if they've been playing violin over a long period of time for their whole life, for their livelihood, there's definitely a lot more strain and stress on that joint, probably a little bit more arthritis there. And when they're having pain, that's the type of person I definitely send to an occupational therapist, because, I'm not a professional violinist. I understand what some of the strains are and, the pressures on it and what's going on in the joint. But at the same time, I think we need like a team approach to say, okay, how are we going to modify as best as possible so this person can still keep performing because it is their livelihood. So that's kind of an example that, I've personally have had a few times in the past, like a musician. And then there are other ones, of course, as well. That's just one that comes to my mind, specifically.
Perfect, thank you. So Preston, what are some common tools or methods used by occupational therapists for pain management?
Yeah, I think like speaking to Dr. Ciccone's example with the violinist is that OTs are we're trained in activity analysis. We look at the person and how they're performing the activity, and we break it down really by movement patterns and what the demand is throughout the whole activity, right? So depending on where we might see the need be is kind of where we're going to intervene. It could be postural, so we might need to do stuff that's like strengthening proximally, working on shoulder strength to kind of reduce any tension further on down the kinetic chain. It could be, like I said, reducing the demand on your hands, so increasing grips for pens or eating utensils, sometimes using specific tools for different kind of diagnoses. So arthritis has a slew of different kinds of tools that would benefit someone to maintain independence with, say, meal prep or cutting or chopping. We have different kinds of tools to help with buttons, so kind of reducing that fine motor demand. And then I saw someone said something about fibromyalgia. So in terms of chronic pain and speaking to that, it's really just, again, looking at the activity. What can we do to maybe change something in the activity or in the environment to put someone in a better position, which puts less of a demand on different kinds of structures that are painful.
All right, thank you. Now, a question for both of you, Preston and Dr. Ciccone. Are there any research or studies that you would want to share with us that demonstrate how effective pain management techniques are?
Obviously, if it's a specific joint like a knee, and if there's very bad arthritis and the structure is a little bit bad, obviously that's going to be hard if you're trying to do, like running versus biking or stationary bike, which might be easier because one's impact and one's not so much impact because it's just more of a range of motion. So in general, without pointing to any particular study, we kind of know that direction is the right way to kind of look about it. Anything that's going to kind of typically do some sort of aerobic type of exercise around that injury is always going to help because in general, it's improving the blood flow situation to it.
Okay.
Yeah, I would agree. I mean, I've seen lately in the research, not pointing to any specific study, but just like active interventions are better than passive ones, especially as we get more chronic. Because we want to keep everything moving, right? If we're not moving, then it could potentially make the pain worse because you're stiffening up a lot of other structures. Some other things that are coming out too are stuff that are more like in terms of patient education or more neuroscience based, which those are pretty exciting to have. I think that they're very helpful for patients. And there's a lot of patient friendly handouts for those that are just, I guess, like helpful in providing insight on exactly what's going on in terms of a chronic pain situation.
Okay, thank you both. So now I'd like to use this time to discuss a few common conditions and how they're treated. So could you tell us a little bit about which conditions you typically see the most amongst your patients?
Yeah, sure. I can go first. I do a lot of spine. So I typically see obviously a lot of low back pain. It's one of the most common things in humans, in modern era. And there's a whole host of different things that can cause back pain. A lot of times it is just kind of muscular, but really a lot of times, whether you have something that's going on in your spine or not, like a disc herniation or arthritis in the spine, a lot of times what's going on, why you're having pain, is because there's a lot of imbalances in the muscles that are supporting the spine. And the muscles, I'm meaning the glute muscles in your buttocks, are actually a major supporter of the spine. So if they're kind of in a weakened form, and I don't mean cosmetically, I mean the actual muscles, if they're not really being engaged, or if they're not what we call firing when you're walking and having a normal, ambulation, or when you're doing normal kind of exercise activity, that can definitely lead to much more strain on the back. So that's definitely something, I send to, my therapists to work on. The other thing is, if your quadriceps are very, tight, that's going to kind of bring you over forward, even if it's very slight. And then again, that's putting a strain on your back, because you shouldn't be too forward or back when you're walking or standing up, right? And then, the core muscles, your abdominal muscles are obviously the other supporter of your whole midsection. So if they're weak, that means the spine's doing everything in your midsection from the back, and then obviously that leads to problems. So those are definitely things that I, see a lot of issues in when people have low back pain. And then, I see a lot of neck pain with this as well. And it's really the same type of situations that are going on, obviously different muscle groups, because we're talking about in the neck and the shoulders, but a lot of times when people's rotator cuffs are not strong, and I'm not saying they necessarily have tears or an injury to it, but they're just kind of not strong and not balanced on either side, it tends to lend yourself to not having a great posture. And then when you don't have a great posture, your cervical spine or your neck gives you a lot of pain. So these are kind of the things that I see on a daily basis that are very, very common. And it's from young all the way to older ages. And some of it's actually work related, meaning sitting at a desk and poor ergonomics. And maybe I'm not even sitting correctly right now. I like to have someone look at me. But that's what I see, probably 70% of what I see on a daily basis.
We do have someone in the audience that works in the garden a lot and is experiencing a lot of lower back aches. Do you have any suggestions for her of what she can do before or after working in the garden?
Yeah, I would definitely suggest, if you're not already, definitely doing, and obviously it's hard to show here, but there's definitely a lot of different stretches that we would use, even if you don't necessarily have a spine problem. Any sort of stretches that are going to stretch out your quadriceps muscles, any sort of kind of basic, very basic with not much weight, but very basic kind of squatting, kind of, maybe a few squats per day might even help. And then a little bit of some core exercises. These things over time, you might notice your back is not going to feel that fatigue after bending over and gardening, which can be very strenuous. Like, even myself, when I do it a couple of times a year, I'm exhausted after it, and I'm not doing those things before. But if you're definitely doing it every day and you're feeling the issue every day, if you kind of lend yourself and just take a few minutes, 10 minutes before, sometime during the day before you're going to do it, and then maybe 10 minutes sometime after, I think that could lend a lot. And, it may not be perfect after, but the comfort level will be better.
Thank you. Preston or Dr. Ciccone, how would you approach someone experiencing rheumatic conditions like arthritis?
Yeah, because I deal with arthritis a lot in my practice. So it really depends on what stage of the arthritis they're at. Some people come in relatively early in a flare-up and they're first exhibiting the symptoms of it. So again, it's like we want to teach them how to use the modalities that we have available to us, especially if it's acute. So like using heat or ice, depending on like where they're going to use it and like what feels better. So like sometimes acutely in the flare-up, the ice will feel a lot better. And then as it progresses, it might feel better to just use some heat. Again, doing some activity modifications. You really want to try to reduce the pressure or reduce the demand on the joints that are having the flare-up. So if you're having having it at the base of your thumb, which is very common for a lot of people, you don't want to be doing tight pinches and tight grasps. So you want to think of like modifying all those activities to the best of your ability. And we do a lot of splinting in the initial stages. Our doctors, our hand surgeons, they will kind of look at doing a neoprene or over-the-counter thumb brace at first to try to get that to calm down. And they do that for about 3 weeks and then use it as needed. So that's what we end up doing a lot with arthritis.
Okay. And how would you approach post-surgical patients?
Yeah. Again, it really depends on what the surgery is. Some surgeries are tolerated a little better than others. So initially in the beginning, like we said before, we're going to compress it. We're going to talk about the positioning of the arm, whether when you're walking, when you're sleeping, and when you're sitting. So it should be raised or elevated. There should be some kind of compression garment on it to help with the swelling, especially at night. Using ice in those stages is great. And then just we use active motion so that when you're cleared for active motion by the doctor, that means that structurally everything is sound. So you just start moving it, and your muscles will actually act as a natural pump to help push fluid out, which can also help to reduce some of the pain that you're feeling from the pressure of that edema. So that's immediately after after surgery, that's kind of how we deal with it.
Yeah, I could add a little bit to that. I think, because then, sometimes people still have the chronic issue after that initial injury, their acute post-surgical pain is getting better, but as they're going through therapy with someone like Preston or something else, they might still be having, these discomforts. And sometimes that's when I have to come in and, sometimes they need a little boost with something. Sometimes there is a small injection that might need to happen with a steroid. Sometimes it just takes a special boost of an anti-inflammatory type of medication to really kind of just get you over the hump so that you can continue the active motion in the correct way and to really kind of push it to get your full ranges back wherever joint or muscle is ongoing. And this kind of leading into, there was something in the chat that's kind of related to this that someone had asked about, and it's kind of related to this. That's why I'm bringing it up now. Kind of where, explaining more of the neuroscience aspect of it. And this is when things could become a little bit more chronic. Sometimes what needs to happen is what's called neuromuscular re-education. And that's what a lot of the, our therapists help me help the patient do, where you kind of have to retrain your brain a little bit to kind of focus on a certain muscle group that you may not have even used correctly before. And now you kind of, there's different things, there's different little feedback type mechanisms that when you're doing therapy that you start to notice these things and then you kind of take that home. So, and someone asks, what would you look for? And, when trying to Google this stuff. And, if you look for neuromuscular re-education towards whatever injury or muscle group you're talking about, you're going to start to see different things, online that you may not have found before without that. And that's really kind of going to get you going, I think, in the right aspect of a correct active motion. And that's even if you're past like us and an acute thing and things you need to do at home when it's safe to do things on your own. That's kind of where I would look for stuff if it was myself looking at it.
Mm-hmm.
Awesome. Thank you. Preston, I know you mentioned a few conditions already, but are there any other specific conditions that you see often?
Yeah, I see a lot of distal radius fractures, so wrist fractures. I see a lot of elbow fractures and a lot of tendinopathies. So like tennis elbow is something that I see often that is painful. Again, we manage them a little differently depending on where they are. Like if it's something that's more acute or chronic, but we're always looking at how to modify the activity and get them back to that level of independence, right? And like speaking to Dr. Ciccone's neuro re-ed, I mean, when you have tennis elbow, you're not recruiting something properly, especially if you've had it for quite some time. So we'll do kinds of interventions to kind of re-educate the muscles in order to promote those healthy movement patterns and reduce the compensatory ones that are causing kind of like malrecruitment or maldemands on different kind of muscles down the kinetic chain.
Okay, when you say re-education of the muscles, could you explain a little bit what that means exactly?
Yeah, so it's touched upon is like if you've had something for a long time, such as chronic pain, then you might not be recruiting muscles properly when you're doing an activity, right? So if you're reaching, you might do like a little bit of a shoulder hike or a shoulder roll, which is going to cause compression and like just bad movement patterns. And so we can use like feedback techniques, whether it be like manual here in therapy or doing maybe some taping techniques to kind of cue you at home so that you're firing them correctly. And so that when you go to reach, you're reducing that height to properly reach for that glass or that plate or that hanger.
Thank you. We do have one question from the audience. Someone is experiencing difficulty holding things from pain or weakness in their hand. Is there any specific exercises that she can do to build dexterity in one of her fingers or her hands?
Yeah, good question. Well, first I would like to see really what the root cause of the problem is, right? Because the intervention for arthritis is going to be different than carpal tunnel. But in general, I would say to increase if it's a pen and you're dropping a pen, like increasing the diameter of the pen. Another thing is to lighten the load. So if you notice that you're dropping your water glass because it's full, I mean, I know it's probably more trips than you might want to take, but maybe reducing the amount of liquid in the glass or the bottle. If it's at home and you're in the kitchen and you are the pan is too heavy and you find that it's slipping out of your hands, kind of modifying that task in general will also help to reduce that demand. You won't be dropping stuff. Like I said, it's hard to say because I would give strengthening for one, but not strengthening for others. So I don't want to say do putty activities or squeeze a stress ball because that might not be helpful in the long run.
Right. Okay, thank you. Are there any advances in the field of occupational therapy or pain management that either of you are excited about right now and want to share?
Yeah, I can start. So there's two kind of just to be very general about two advances that we are excited about in the pain management field. There still needs to be a lot of work done on it, and we don't have necessarily the full results on a lot of these. But the first is, and I'm sure many people have heard of it, is regenerative medicine type things. The jury is still out on, you'll hear a lot of stuff about stem cells and, generating things with stem cells. Right now, there's still not a lot of great science behind that. But that is something where, I think the technology is getting better in deciding which cell lines might actually help improve certain pain conditions or help rebuild chronically damaged tissues, we'll say. But the jury's really still out on that. There are other things in regenerative medicine, such as platelet-rich plasma, which does have some results that are reasonable for certain conditions, certain tendinitises that are chronic that haven't been helped with all the stuff we're talking about and even basic injections and with therapy, and we're talking about over a long time. And there is some mild evidence for chronic knee arthritis, for platelet-rich plasma. It won't halt the arthritis from happening. We can't change the structure of that knee aside from doing knee replacements if it's at that stage. But it can sometimes give a decent amount of time where it kind of changes the environment in the knee where it's not as inflammatory over time. So meaning the pain could be a little bit better. And then maybe you could do better with exercise. So that's one field that a lot of us in our field are excited about. And then the other field, which is a little bit more advanced, is something called neurostimulation. These are usually little implanted devices that we use to change some of the nerve signaling when we can't get the correct neuromuscular re-education from the traditional approaches, where we can cancel out certain pain signals. And again, these are usually reserved for pretty serious conditions like different spinal issues or things like that. It wouldn't be for the basic little, certain things in the periphery per se, although there is some peripheral nervous stimulation out there. It gets a little complicated. But basically that this is kind of where, I'm excited about these advances. They've been around for, a good decade or two, but they keep getting kind of better every year, just like your phone gets a little bit better every year. It's the technology's getting better and they're getting more precise in where we can affect things. And actually their effectiveness is getting more precise as well.
Yeah, I mean, I think too, like we're seeing, I mean, this is specifically pertaining to tennis elbow, but we're seeing like more and more research supporting addressing the radial nerve in tennis elbow as helping to relieve some of that pain that people are experiencing. We're getting really good results with it. So that's something that's just exciting from a hand therapy standpoint.
Awesome. Thank you for sharing, both of you. And our final question, what would you share with someone living with chronic pain? Do you have any advice or anything that you would want them to know?
Yes. So a main thing is, main thing to be, cognizant about throughout if you have chronic pain, and I know it's difficult, but a kind of positive attitude and not, versus a what we call a catastrophic type of attitude. We know that if you continuously kind of think in a certain way and catastrophize where everything's really bad, and I get it can be very bad, but that kind of way of thinking, that it can kind of have a bad cycle where you start to have bad feedback on what you're doing, and it can actually make the pain worse. So that's one thing I would suggest for people with chronic pain to try and avoid. Also being realistic, we can't be 100% with a lot of these things. Unfortunately, we're in a gray area with a lot of things we treat, and it is kind of a chronic conditions, just like high blood pressure or something like that. But being realistic, actually, and setting very specific goals and at the right time periods in your, management of it can actually really help you get better over the long term. So that's something I kind of tell all my patients.
Yeah, and I usually tell people, I usually just give the spiel of like, we want to keep a positive attitude. We want to make sure that we're eating healthy, that we're doing, healthy exercises, and that we are having like a healthy sleep pattern. So, because there is a correlation between poor sleep hygiene as well as like an increase in chronic pain. So those things I like to highlight. I also like to highlight just our energy conservation techniques. So, planning your day out and prioritizing those activities so that you're able to accomplish them in the best way possible. So.
Great. Thank you both so much.